Critical appraisal of randomized control trial. So the study I had to read was rosiglitazone evaluated for cardiovascular outcomes and oral agent combination therapy for type 2 diabetes, a multi-center randomized open-label trial. So the study I read had 4,500 patients with type 2 diabetes on metformin or sulfonylurea monotherapy with mean H1AC 7.9% previous to being entered into the study. They were then randomly assigned to the addition of rosiglitazone or to a combination of metformin and sulfonylurea. The primary endpoint was cardiovascular hospitalization or cardiovascular death, and it was analyzed based on intention to treat. Are the results valid? So the patients were randomized by telephone from a dedicated center using random rearrangement and were stratified by background information such as their age, sex, ethnic origin, previous medications, and cardiovascular medical history. Patients were also included in the study based on eligibility criteria or exclusion criteria. The trial did not have adequate allocation concealment as it was an open-label trial in which both researchers and participants knew which treatment was being administered. It was an open-label trial because of planned differences in the strategy for rescue therapy and the need to follow different types of doses of comparator sulfonylurea therapies. This table shows the number of patients that were lost to follow-up. So 4,458 patients were randomly allocated at the beginning into the study groups. 11 did not partake in the study and were excluded from the analysis. 2,220 patients were randomly assigned to rosiglitazone, and 2,227 were randomly assigned to either metformin or sulfonylurea to their current monotherapy. 127 patients, 60 rosiglitazone and 67 control. Their vital stats were unknown at the end of the study, and another 394 patients were alive but withdrew from study visits, so their cardiovascular endpoint information was missing. In the 12 months following the completion of the study, 32 people withdrew from the randomized treatment, and the withdrawal was slightly higher in the rosiglitazone group. The primary hypothesis of non-inferiority was tested on the randomized and treated population and analyzed based on intention to treat. A sensitivity per protocol analysis was restricted to each participant's time on dual combination therapy, and patients who dropped out of the study were not included in the analysis of the results. So what are the results? If you look at this graph, you can see that rosiglitazone and the active control group, which is metformin and sulfonylurea, are pretty much the same during the 5 to 6 years that patients are on the study. The event rate was 28 per 1,000 person years for the primary endpoint, which was cardiovascular hospitalization or cardiovascular death. And the primary endpoint occurred in 321 people on rosiglitazone and 323 people in the active control groups, respectively. The hazard ratio was 0.99 with a confidence interval of 0.85 to 1.16, which indicates the pre-specified criterion of non-inferiority was met for the primary outcome. So the table on the left shows the type of cardiovascular deaths and hospitalization by treatment group. For cardiovascular mortality, the rosiglitazone group had more heart failure-related deaths, but fewer stroke-related deaths than the control group. And for hospitalizations, they were about equal, but the rosiglitazone group had more heart failure hospitalization and fewer stroke hospitalizations and fewer cardiovascular procedures than the control group. The table on the right demonstrates that the mean HA1C at 5 years was lowered more in people who were randomly assigned the rosiglitazone, whereas body weight, HDL cholesterol increased more, and LDL cholesterol was reduced less than the groups randomly assigned to either sulfonylureas or metformin. And how can this be applied to patient care today? Well, rosiglitazone should not be recommended for patients with heart failure, myocardial dysfunction, women at high risk of fractures, and there's no evidence that rosiglitazone increases overall cardiovascular morbidity and mortality compared to metformin or sulfonylurea. Rosiglitazone is recommended for patients as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes mellitus for whom all other oral anti-diabetic agents in monotherapy or combination do not result in adequate glycemic control. Critical appraisal